and these are normally capable of accessing the COVID-19 vaccination, maybe through the private health sector, that is the corporations, individuals, organizations, and the diplomats. Now, vaccine approved under the COVAX facility will be used for all these segments. All vaccine imported for use in the public and private sector must comply with this standard. Now, monitoring and surveillance. As I said, this vaccine, the AstraZeneca, while it has been licensed under the emergency listing, we still need to do a lot of monitoring and surveillance to look out for other side effects in simple terms. So the sequence of events and tool of development, pre-registration of individual. We have undertaken micro-planning, and this work has been contracted to Makerere School of Public Health to help us identify where the risky groups are. So in each of the districts, we shall list the people who are in each of the different age group. And we need to know the individuals such that we can, in a well-sequenced way, offer the vaccination. So all this information is going to be linked to the national database of the Ministry of Health, and we shall be knowing how many people we are vaccinated on a day-to-day basis. Now, at the vaccination point, there will be a lot of screening to ensure that we are giving the vaccine to the right people, and this would involve people presenting their national identification, and then they will also be receiving general counseling, and then they will also fill consent form before being vaccinated. After being vaccinated, we shall monitor you for up to 30 minutes, depending on how your body responds to the vaccine. You'll also be given a card that you will be using to show that actually you've received maybe the first dose and you are due for the second dose at an appropriate appointment. The recording of all those vaccinated will happen in our register. We shall monitor the adverse effect following immunization, and whichever adverse effect happens, we shall document it. This will be handled by specific committees nationally, and we shall afterwards give feedback to the community. Now, as I said, the vaccine will be in Uganda by 6th March, and immediately logistical work will begin to have it transported to the districts based on the number of the people to be targeted in the first phase. So the sites that are going to work in the district will basically be the hospitals, health center 4s, health center 3s, and maybe center 4. Where you have a regional hospital, we shall do the vaccination at the regional referral hospital. Now, the vaccination will be done in phases to allow monitoring of the side effect. And for instance, if we are vaccinating the health worker, we cannot vaccinate all the health workers at once. It will cause a crisis. So the health workers, if you are 10, we may vaccinate 3, and then skip a day, vaccinate the other 3, such that those who are vaccinated first can report back to duty. So this will be done in a well-sequenced manner to avoid interruption of continuity of service. This is just a sketch to show you the flow if you are coming for vaccination, where we have our SOP being followed with a demarcated entrance, hand washing, and then you are screened, your temperature taken. They make sure that you are really the right person coming in for the vaccination. Thereafter, you undergo personal information is entered into records, and then thereafter, the vaccination happens. After the vaccination, we shall monitor you. As we have developed this, we have made sure that at every vaccination site, we must have a medical officer who will assist in case of any adverse effect following immunization happening. And therefore, for all those who will be vaccinated, they must stay within the premises for at least 30 minutes before being allowed to go home. And then as you leave, we make sure you still wash your hands, and then you exit. Currently, what is happening? Since yesterday, we started on embarking of training of health workers. As I speak now, day 2 for training of health workers is happening, and we are training the regional hospitals, the team from the DHOs, and the national trainers. Thereafter, we are going to embark on training of the district health workers. So this is something that will be happening in the next couple of days. And we hope that by 3rd March, all the trainings will have been completed. Now, the adverse event following immunization, we need to take record of this, as I earlier hinted, that all vaccinating sites will be prepared to respond and effectively manage any adverse event following immunization. Each vaccination team will have a medical officer who will manage the AEFIs that will occur within 30 minutes. We shall provide them with the kits. These kits have the emergency medicine, and all vaccine recipients shall have to remain for 30 minutes on site. We shall provide some resting corner, but with SOPs of social distancing ensured. We shall also have an emergency ambulance in each of the districts just for preparedness. We do have reporting tools that we shall be using, and this will ensure that we collect information in a timely manner. What are the common AEFIs from the AstraZeneca vaccine? These are really based on the interim analysis from the pooled data from the 4 clinical trials done in the UK, Brazil, South Africa. The most frequently reported AEFIs were mild to moderate, and these resolved within a few days of vaccination. The common ones is just the tenderness at the site of injection, the injection site pain, others reported headache, fatigue, malaise, fever, chills, joint pains, and others felt like vomiting. The adverse events reported after the 2nd dose were mild with less frequency. Therefore, this should not deter anyone from receiving the 2nd dose. The serious AEFIs reported, like any other vaccine or drug, may include anaphylaxis, although this is very rare. Now, what are the next steps? So far, I would say up to number 7, number 6, that's where we are. We are doing now the regional training, and we shall be embarking on the district training by 1st to 3rd March. District micro planning, as you already know, we said we need to identify those who are eligible for the under phase 1. We need to know who are they, where are they, and where they receive the service. So micro planning will entail doing all that work to enable us plan better and have an effective coverage in terms of achieving 100% coverage. As I said, the vaccine will be here by 5th March when we have done almost all the work within the district, just ready to embark on the exercise. So we do hope that the distribution of the vaccine will be completed by 15th March. And then there's a planned national launch on the 16th March. And then thereafter, the vaccination will start. That is by 17th of March. Thank you, members, for listening to me.
Thank you, Tanwa. I understand that UNICEF might like to comment, and I give the floor to Munir and Viorica.
Thank you very much, Dr. Yonas. I am asking my colleague Viorica to step in with very brief comments. Thank you.
Thank you very much, WR and Munir. I would just like to add a couple of comments on the role of UN agencies in supporting the COVID-19 response and COVID-19 vaccine deployment. It was implicitly mentioned in the presentation, but I would just wanted to add that UN is currently developing the plan, which will represent a joint framework for our action. And that is being developed through the weekly meetings of UN Health Emergencies team that is led by WHO. We're meeting every Friday, and we have an advanced version of the plan, which outlines key areas for our support. I just thought it's important that I flag those, because what we see now, we see kind of fatigue that is installing in that response, and anxiety and complacency. They are all mixed. And one of the very important action from all UN agencies, both involved in the emergency response, involved in the vaccination, but also in essential social services continuity, is that we do everything we can to support the national government, either through technical advice or otherwise, but also to help districts to improve their reporting, to improve their readiness for the imminent deployment of vaccines. And the other thing I wanted to stress is the role that UN agencies play in the deployment of COVID-19 vaccines. You have noted that we are expecting the first shipment to arrive by 5th of March. And I believe that relates to the import or bringing in COVAX financed vaccines. You may know that COVAX is a kind of global facility that was set up last year by WHO, Gavi, CEPI, and a few other partners to ensure equitable access to vaccine. UNICEF has a global role to support the deployment of vaccines that are allocated by COVAX facility to, together with PAHO for the South America region, to essentially every single country in the world, the majority of countries in the world. And we have an important role in also WHO, under the leadership of WHO, to ensure the country readiness to receive the vaccine, to prepare them. And you've seen Dr. Emmanuel, he showed a lot of actions that are already taking place. So the first wave of 864,000 doses is expected to arrive by the end of next week, hoping everything goes as planned. But I also wanted to flag that the government is engaged in negotiating bilateral deals, and there will be additional doses being brought in based on the agreements with Serum Institute of India, donation from Government of India, and few other countries. So let me stop here. Over to you. Thank you.
Thank you, Viorica. That was very important message. May I give the floor to IOM if they want to comment anything before opening the floor for answering the questions? IOM?
Good morning, colleagues from Sierra Leone. On my side here, I have nothing to say. I will ask Dr. Marius or Dr. Mukunda if they have anything to, if they have any comment to make, let them please comment. But so far, the presentation this morning is very informative from Dr. Yonas, from WHO, from Dr. Desta, and also from our colleague, Dr. Viorica just now. Thank you very much.
Good afternoon, everyone. Thank you very much for your presentation. Extremely instructive. We are definitely committed to stay involved together with the UN community in defending UN community against this pandemic, which has large implication psychologically, economically, whatever. I will skip my speech for answering the questions I've already seen. Thank you again, everyone.
Thank you. Tatsu, if you would allow me, I'll try to answer some of the questions and ask the panelists also to come next. To start with, some of you asked, first of all, there is an extensive questions on the science and more detailed questions in your chats. We will get back to you with a written response because some of it take a long time to explain, and we'll do that. Just to touch up on some of the issues, UN staff in Uganda would be treated the same way as the population. So let me be specific. Almost all of us, whether international or national, are registered with the National Registration and Identification Authority. And those databases will be used to identify, for example, health workers, frontline workers, and so forth. And also it will help in identifying people above the age of 50. And how people would identify their comorbidity so that they will be given priorities will be something currently worked on, and that will be communicated to the public, and we can all participate in that. If by any chance the national system does not fulfill the requirement, then UN is looking into that. And as Rosa says, that the UN system has communicated with the head of state to ensure that the UN is included in the national prioritization. Then there are questions about the choice of vaccine. Generally, I think most of the vaccines will be from AstraZeneca, but even I can tell you that the Ugandan government is looking into the other vaccines and is also at the same time waiting for WHO to ensure that these vaccines are assessed and are part of the pre-qualification. For that matter, for example, the 2 Chinese and the Russian vaccines are already in the assessment levels. And for the Chinese vaccines, we'll know the verdict in March. The other question you mentioned here is about the variant. I think what we can, currently there is monitoring by UVRI and other labs if there are any variants happening. These variants which are has increased their transmission are those who were initially identified in South Africa, in UK, in Brazil, and another variant is appearing now in New York. And those has not been up to now identified in the sequencings made in Uganda, and further work will continue. But each one of us contribute to that by making sure that we comply to the public health measures. The other question asked is about reinfection. As you know, COVID has few but credible reinfections. The guideline up to now is that people who have infection after a certain time would be included in the vaccination, and we will provide you more information on the timing and how those things would be. I think I'll stop here and ask Tanya to answer some of the questions, to be followed by Salome. Tanya.
Thank you, Debriara. I have so far received a good number of questions. One of them is asking about the vaccine monitoring. As I said, this vaccine is under emergency use listing, and therefore the process under which the vaccine monitoring is established are still being conducted. It is a matter of time that they will develop the right vaccine monitoring. As I said, this has been done within a shorter time. It requires more time for the scientists to develop an appropriate VVM for monitoring this. The vaccine monitoring, as I said, it helps us to know whether the vaccine has been exposed to high or very low temperature. That's why we said that our vaccine is stored between +2 to +8. So if you expose it to heat, it gets damaged. And the safety we have is that we must ensure that we follow the cold chain procedure. We must have the temperature monitoring within the vaccine carriers, within the fridge, to know and take record of the temperature throughout the period we have the vaccine. Therefore, this is work in progress. With the time, we shall have the vaccine monitoring. Now, the other is the use of the vaccine in the immunocompromised. Still, this vaccine is under investigation. More of the monitoring are still being done, and we don't have the right information as of now. But with the time, the scientists will be able to tell us what has come from the various use in the various regions. So as of now, we shall continue to be advised. I don't know what Dr. Bodo has to say on this. Dr. Bodo, are you there?
Yes, thank you.
Answer.
I'm on, yeah. Do you want me to respond now?
Yes, respond to now and the other questions which I were forwarded.
Yes. For the vaccine, the recommendation, much as it's not known how well the immunocompromised will respond to the vaccine, but usually what we try to avoid in those who, like, for example, who are immunocompromised, are vaccines that are live vaccine or live attenuated, and this vaccine that is being used, many of the almost all of them are not live attenuated. So the recommendation, yes, is that even in immunocompromised person, they should be given the vaccine. The only query is how well they will respond to the vaccine. Do they develop adequate immunity like any other person? That time will tell. But for now, the recommendation, yes, they should also be given the vaccine just like any other person. Over to you.
Thank you. There was another question of somebody who has the DVT. What is your take on that?
Yes, the deep vein thrombosis, or the risk of having or developing a clot in your body. What is the recommendation regarding whether should such a person receive a vaccine? Yes, there's a small risk, because usually such individuals are on drugs that thin their blood and prevent them from clotting. And so there's slight risk that they will probably bleed into the skin after vaccination. But the recommendation right now is that once you're given that vaccine, you should apply pressure to the point where the vaccine has been given. And but you should receive the vaccine normally, but with the added precaution of looking out for any bleeding under the skin that may occur. But the benefit and from the studies in the UK, that has not been much. And the recommendation is that you should receive the vaccine normally, but watch out for any small clot that may form under the skin. The advantage of receiving the vaccine outweighs the risk of getting a small blood clot that may form under your skin from receiving the vaccine. Over to you.
Yeah, thank you very much, Dr. Bodo. Now, the other question that has come up is that for those who have contracted the COVID-19 vaccine disease, should they be vaccinated? Yes, they will be vaccinated. However, the recommendation is these should be vaccinated 6 months after. So if you contracted the disease, say January, then you are likely to be vaccinated after July. The simple science is we still don't know how their bodies behave, but even then, since they have just contracted a disease, it is not good to again vaccinate them. But however, after 6 months, they are eligible for vaccination. The other question is that after vaccination, are you at liberty to start moving around without following the SOPs? No. We advise that irrespective of the vaccination exercise, continue following the SOPs in place. Remember, we are only vaccinating a very small percentage. If we can reach about 90% of all the population, then thereafter we shall be guided on the next steps. But as of now, let us continue with the vaccination exercise and follow the SOPs in place. Dr. Bodo, there is a question about allergy. As remember, there is a recommendation that this vaccine should not be used by those who have any known allergies. Now, if you have allergy to eggs, I don't know what Dr. Emron would want to say here and Dr. Bodo. Would that be a contraindication, or you would want to screen these people ahead of time?
If I may intervene, one, if we can focus on deployment, we will answer all this detail in writing, because I see a lot of similar questions.
Okay, WR noted. I've not seen the specific question on the deployment.
Okay, maybe
do you want me to probably comment on that allergy? Yes. There is a clear, before one receives a vaccine, there is a clear, and I think Tenyua showed one of the tools, there's a clear screening tool that will be applied to every individual before they receive a vaccine. And one of the thing that will be looked for is a history of reaction, not just simply you having allergy, but history of reaction, severe reaction to vaccines before. And it's not totally, it will be at the discretion of the, with all the guidance that is there, that is taught, the health worker, decide whether you should receive the vaccine or not. But having had an anaphylactic reaction, that means severe reaction to another vaccine, does not necessarily mean that you will have a severe reaction to the COVID-19 vaccine that you've been given. The issue comes around if you, so you will have, they will determine the level of severity that you've had, the level of severity of reaction that you've had to any previous vaccine. But also more importantly, the only exception is if on this first vaccination you develop a severe reaction, the exception then will be the decision to withhold subsequent vaccine administration that you will be expected to have because of the risk that the second time you receive the vaccine, the reaction will get more severe. Over to you.
Thank you, Bodo. I will now give the floor to IOM. There are specific questions to them, and then to UN Clinic. And if we have time, I don't want it to be totally dominated by our WHO response. And I would like also for UNICEF to respond on some which. To you, IOM.
Dr. Marius, can you please respond to some of the comments, please? Thank you.
Dr. Yonas, can you say again, please?
There were questions which Dr. Julius was trying to get, and there were questions, if you want to respond to that.
I'm terribly sorry. What the question was, please?
Okay, I'll pass to UNICEF and get back to you.
Thank you.
Thank you, WR. I wanted to make 2 points in relation to some of the questions that were raised, maybe to make them a bit clearer. There was a question about safety, vaccine safety monitoring. So on the one hand, so people were a bit confused by the fact that they are safe, but we are still monitoring safety. So why is that? So what I would like to say about that is that safety monitoring is a standard practice for any vaccine, even for the vaccine that have been introduced decades ago. And this is something, you know, the medicine is not exact science, so we always learn something new. And this is why safety monitoring is a standard practice. It becomes even more important when a new vaccine is introduced, because even though the vaccine trials have come up with the results that most of the complications are mild and moderate, and many people will not feel much, they are still there. So this is important regardless of whether vaccine is new or is old. So it's a standard practice and it is for the safety of everyone. So that's number one I wanted to say. And it, again, just to say that nothing that is not safe based on the information that is known is being recommended. That's why these reviews by the various technical agencies or regulatory authorities is going through several stages, and vaccines are undergoing a specific scrutiny. And the other thing that I wanted to tackle, I saw the question about do we need to test before getting vaccine, and how we're going to test if there's shortage of tests. There's no hard recommendation to test. It's actually not recommended to test before immunizing. If you are not in active phase of the COVID-19 disease, you can be immunized. I think one of the reasons for why delay may be recommended, in addition to what was mentioned by WHO colleagues, is that the key issue is that supply of vaccines is limited. And this is why colleagues, so people who have already developed the disease, have a certain level of immunity, and allowing those who didn't have the disease or think they didn't have the disease to get immunized to get a certain level of protection. Getting vaccinating under the COVID-19, based on the current knowledge, is not a contraindication and can be done without being tested. So let me stop here. Over.
Thank you, Viorica. The question for IOM was elaborate more on how the IOM remote monitoring system works. Over.
Thank you, Dr. Yonas. Remote monitoring is done by our professionals, nurses and physicians. It consists of twice a day medical checks on vital signs like temperature and oxygen saturation, and symptoms over the phone or over online conferences. Based on our professionals' recommendation, home care kits and medication may be included. Home care kits consisting of masks, hygiene items, thermometer, pulse oximeter, and if needed, medication can be added. We do have an email enrolling and a telephone number, which I think I answered in written on the Q&A folder. So that's pretty much it. it's a real remote monitoring. Yes, I forgot. Our professionals will give to those enrolled the basic instructions for self-isolating, consisting of good habits, good practices, hygiene, and so on. Over to you.
Thank you, Dr. Tafari, for some of the questions raised.
Thank you, Dr. Yonas. Please, if you can remind me about the questions. I remember one question mentioning that medical insurance coverage covers other clinics and hospitals. Therefore, as far as we are covered in nearby hospital, we are not forced to go to UN clinic. So this was one factor, and this is welcome. Yes, this is an observation I saw from the Q&A, but if there are other questions, I'll be happy to answer. Thank you, Dr. Yonas.
Thank you. Jamshed wants to answer one of the questions. I know he's not around, but I give the floor from his remote location. Jamshed, maybe he's not connected. Okay, there are few people who have their hands up, and Stella, you can speak.
Hello.
Go ahead.
Thank you very much for giving me the opportunity. I think I indicated that since mine is much more a personal health-related one, that I would appreciate if I could get email feedback. Thank you.
Thank you. If other panelists don't have a question back, I will give first to Salome if she has anything more, and then I'll go to the other WHO staffs to give more answers. Salome?
Thank you very much, WR. Mine is just an addition to something that you had mentioned earlier about the variants and their presence in Uganda. And just to alleviate fears of members here, that we are monitoring for the presence of variants, but also for all of us to realize that variants are a normal progression in any virus, you can say, moving through the community. And that is why it is very important that we maintain all the SOPs as guided by WHO, by Ministry of Health, wearing the mask, social distancing, and hand washing, just to maintain that we keep those SOPs in check. There was also a question on where that information is. We will be sharing links to the WHO genomic sequencing surveillance data so that members can follow through as they wish. Thank you very much, WR.
Thank you. Now I'll give back to Bodo to answer some of the questions on the clinical aspect of it. And let's spare time to, there were some administrative and other questions. Maybe Tatsu and Rosa will come on that, or any of the other panelists. Please let me know. Let me see your hands if you want to answer any of the questions. Bodo, you want to answer some of the clinical questions. To you, Bodo.
Yes, thank you, WR. Thank you, WR. The questions, maybe what I wanted to answer has been answered by Salome, that there is a situation updates that WHO develops on a daily basis, and it has got a number of countries reporting the different variants. And then the second question that was asked is how is the issues around the community distrust and misconception around the vaccines being addressed. This, as part of the national deployment and vaccination plan, there is a very detailed component of risk communication that is being that has been included and will be activated or is being activated, and hope that will address, of course, not totally, but that will address many of the concerns that people are raising out there for us to have a very good vaccine uptake. I think that is really what I wanted to say. The rest, I think, have already been answered. Over to you.
Okay, just for your information, I'm showing some of the maps you can use from the WHO weekly epidemiological report, which is available on WHO website, where you can see the map of the various variants. There are more databases, but we'll share them at another time, those. Alex, you want to say?
What's happening?
Thank you, Deborah. I've made my comments in the chat. I've responded to most of the questions, which were general on COVID. But just to emphasize that it is still important for people to put on their masks and practice all the necessary measures after vaccination. Remember, also talking about the new variant, which Solomon actually pointed out. The evidence in South Africa is that some of the vaccines were not effective to the new variant. So it is always important for us to make sure that we continue practicing all the necessary measures. Thank you.
Okay, I don't see any of the other panelists volunteering to answer more questions, so we'll try to give a written answer.
I have some questions.
Tanwa, you have the floor.
Thank you,
I was hoping that I will see your hand.
Now, there is a question about what are the plans of communicating to the health workers and making them aware about the plans on the vaccine. I would want to say that the Minister of Health is working about the communication to the public and in particular to the health workers. There are already programs, and I hope Viorica could even point out this because it is being supported by UNICEF. So the issue of awareness about the vaccine is in high gear, and it should already be on the radios, and I think by next week it will be on the televisions. So work is ongoing. Now, the other part is some people didn't understand by what we meant by screening at the post. Screening, we're not going to test you whether you have COVID, but we shall ask you some questions to guide us to understand what your health status is. So for instance, we shall ask you, have you suffered from COVID before? If so, when did you get diagnosed? Something of that nature to guide us on what we should advise you to do, whether to get the vaccine or not. And the other would be looking out for the other general medical condition known by you. So screening, we're not going to test for people to know whether they have COVID or not. So the screening, the medical screening here is simply to know your health status. Now, WRR, there is still a question about safety of the vaccine, but I want to assure the listeners here that this vaccine is very safe and effective. That's why it has been put into use. So the issue of safety shouldn't be of any concern because it has gone through the stages of approval. And that's why it is under the emergency use listing. So maybe WRI, you could add on to this because some of the members were asking, is it safe? Why is it under emergency use? Because of the short route it has taken. Over to you, WR.
Thank you very much. This vaccine goes through a rigorous evaluation. The scientists look into the data And it's after that that they will tell us it's safe. But at the same time, these are chemicals and these are biological products. So there will be minor side effects. And as this virus is new, there are things which we don't know. But compared to the risk and considering the public health needs, it's the best that we have to get out of this pandemics. It is very safe, and we can provide you more information on the safety of it. The reason why it is under emergency use is that for it to be fully licensed, there are additional requirements, and those requirements are not there yet. If you remember, for example, the Ebola vaccine was also an emergency use, and now it is licensed after documentation and so forth. So those processes will take time, but the disease does not give us that choice. And I can guarantee you, if I am one of those to receive it, I'm willing to take it and show you that it's safe. Viorica, you want to say something? I know you are writing something.
Thank you, WR. No, I was trying to add to the question about risk communication and just update the audience on the fact that the Ministry of Health is monitoring social media and has developed the social media campaign communication plan, which is due to start before the end of this week. All the other messages have been packaged for various channels in various forms for various audiences, and that includes frequently asked questions, social media posts, radio, video materials, leaflets. They are under review and clearance by the MOH. We are expecting that once cleared, that can start next week. But one of the key challenges for that has been availability of operational budget. Having said that, there are some small seed money that can be used to initiate communication. Over, and thank you.
Thank you, Viorica. There would be a big effort to fight vaccine hesitancy. And as more science is becoming available, more operational decisions are made, we'll try to provide you more updates and also respond to some of your questions which are here. I know there were questions which maybe Tatsu and Rosa and others might like to respond. First, I'll give them the floor, and after that, I see one attendee questions. I will go to that. My apologies, managing a webinar for such a large group is not an easy one. Tatsu.
Shall I go first?
Tatsu and Rosa.
Can you hear me?
I'm blocked there.
Now we can hear you.
Okay, good.
We heard what, can you hear me?
Yes, I can hear you, Yonas. Thank you. Sure. So let me look at a couple of the questions that have that are administrative in nature. So I see some questions about SOP. Some of the colleagues are asking about the percentage of the people coming back to the office. For example, we've got a question from the Entebbe colleagues, we've got a question from the IFAD colleagues as well, saying that the phase 2 percentage doesn't really meet with the reality that their offices are facing. But here, maybe I can say a little bit about how the SOP is supposed to be translated. Because this is a recommendation from the colleagues jointly worked on the SOP. But at the same time, we also specified in the staff advisory as well that each office may be facing a different environment. You may have a much wider space in your office, or you may have only a very, very tiny space where you can even, for example, only 10% or something of the demand that, if you're really trying to meet with the social distancing requirements. So each office is supposed to be actually coming out with SOP, and that's also by referencing the staff advisory that we have shared recently. Each office is supposed to come out with their own formula. So it may be possible for some offices to have slightly more than what the phase 2 percentage says, or may not be even possible to move into the percentage that the staff advisory is suggesting. So that's what I can say about the office space and percentage. So again, each office is supposed to be looking at their own environment facing, and they have to make a decision on that. There was a question about the update of the SLPs. Yes, this SOP or the staff advisory has been updated on a regular basis.
Every month.
And again, the question was about the SOP is going to be updated after people are vaccinated. Probably yes, but the SOP also continues to be a subject of the updates depending on the COVID situation, depending on the pandemic, etc. So this is what I can say for now. There was a question about the selection of the UMC, which Dr. Teferi mentioned in the PowerPoint slide. For this, I would like to request Dr. Teferi to address this question. Why is it UMC and not Morago or not something else? So Dr. Teferi, I would like to request you to address this after I finish addressing questions. Is there any other way? I think I addressed the questions. Rhoda, do you have anything to add?
Of course.
Okay, then Rhoda, please add. Yeah.
So good afternoon. I don't know if you can hear me. Can they hear me?
Loud and clear.
Okay. So first of all, my appreciation to all the medical colleagues who have provided the explanations so far. Two things that I wanted to clarify, and I responded to some of them through the private questions that came in. Number one, regarding the staff advisory, we review it every month. If something happens more frequently, it gets updated at that time. And number two, the recommendations that we give are the recommendations to guide what each agency is supposed to assess. So for example, in the case of Entebbe, there were some issues and concerns regarding the training and workshops. So we had a particular exchange with Entebbe in order to address their needs so that they could sustain their critical operations. I also want to use the opportunity to recall to all staff that all agencies are supposed to send their updated programs and modalities of implementation to us to help us keep track. So that is part of the interpretation that is there. In addition, as UN heads of agencies, we agreed that best practices would be shared and encouraged. One of the best practices is having alternate teams, especially for those offices where they need to have a significant number of staff in order to sustain their life-saving operations. So they have team A and team B, and they have different days when they come in and they go. So again, I really call on all staff to sit down and have a conversation with their country representatives if they feel like they want to change their role or their position, because each agency's business continuity plan is what we are using also to inform this overall guidance. So I wanted to put that in there. I also wanted to flag the offer made by WHO several months ago to organize training for cleaners of UN premises to make sure that the way they clean is actually in accordance with WHO guidance. And I know several of us did benefit from that training, and I encourage those who have not to please reach out to WHO to make sure that it takes place. Third thing that I wanted to flag, which I've also been getting some information on, is the issue of mental health. There is extremely high levels of burnout across the organization because everybody is stuck in place. And as part of that, there's been a discussion at headquarters level with some of the insurance companies to see how to facilitate access to counseling for all staff. So again, please, you can reach out to Dr. Teferi and the health team. If we need to restart counseling sessions in groups for the staff, let us know. I believe we did that last year after the lockdown. It is a very tense and difficult time, but please use the resources available. And if you need help, you can ask for help accordingly. I think those were the only things that I wanted to reply to. I think the other question that I found there, somebody was asking for clarity regarding the travel requirements regarding COVID. Does it apply to all staff? As we said, yes, all staff except those coming from countries with the variant 501. Now, what we are really focusing on regarding the 5 and 10 days is for program criticality to access UN premises. So this is where you need to be in touch with your office to find out if you're a critical staff or not. Thank you.
Thank you, Rosa. Teferi?
Yes, about UMC Hospital. This question has been asked also directly to me, why we are preferring UMC. Yes, UMC Hospital is one of the 2 accredited hospitals to admit and care about coronavirus cases. And this is one of the main factors why we are aggregating around UMC, also for non-COVID medical treatment. Dr. Simon has initiated, earlier on, entering contract with the UMC hospital, because normally they accept cases from the regions by only telephone call. And as far as it is a medical insurance which covers expense, it was easy for us to grab any hospital willing to do this service. But now we are formalizing UMC because we are dealing with COVID also. So COVID and non-COVID with UMC hospital. But this is not the last, because any hospital providing better service could be accessed for another agreement. Thank you.
And thank you, Yonas. I just wanted to reemphasize and what Dr. Teferi is saying. Dear colleagues, please know that all the arrangements we're making are not just for us. Some of this spills over to our colleagues from the peacekeeping missions who come here to seek medical assistance. Thank you.
Thank you, Rosa. I will, if people have questions to ask directly, they can raise their hands. In the meantime, I understand my team wants to answer some additional responses. I'll give the floor to Bodo.
Yes, thank you, Dr. There's one question maybe that I wanted to have seen it directed to, I thought Dr. Desta could answer. The question reads that while staff are being evacuated, say from Kampala to Entebbe, to board the evacuation plane, who keeps them company in the ambulance? Is it the UN medical personnel or the government medical personnel?
UN, that's easy.
Thank you. I would just like to inform you also that WHO is arranging to ensure that the UN has its own access to ambulances, and we are making arrangement on that. So that will also help us to give a better service for our staff. We are looking into expanding the number of beds and also use what we call the shuttle, epi shuttle, to ensure that people who might have been infected can still be transported across borders in a safe way. But this will keep you updated as well. Any other person who has a question or a response can raise their hands before I hand over back to Tatsu. or I might as well do it. Hand over to Tatsu now.
Okay, thank you very much, Yonas, for this question and answer session. And also thank colleagues for making presentations. Now, it seems like we have come to the end of the questions. So now I'd like to hand over the floor back again to the RC to make the final comments for the town hall meeting. RC, please.
No, so I want to end where I began with conveying my appreciation and thanks to all UN staff and personnel working in Uganda, for Uganda and for the region, and actually I can say globally as well. I also want to reiterate my thanks to all our colleagues at the front lines in terms of the COVID response, in particular WHO, UNICEF, IOM, and the UN Clinic. And I want to reiterate my call to all UN staff to please make sure that both you, your family, your colleagues, and the partners adhere to the SOPs issued by WHO. As you can see, progress is being made. We are learning something new every day, but we are definitely not out of the woods. We will schedule the next town hall meeting after consultation with WHO, the next time that there's a milestone in terms of update of the situation. Until then, thank you very much for your attention, for your commitment, for your support, and for the work you do for the people of Uganda. Have a great day.
Thank you, Rosa. And thank you to all who has contributed to this.
Thank you so much.
Thank you, everybody. Have a safe weekend, please.
Thank you.
Thank you. Goodbye.
Thank you, everyone. Thank you.
Thank you, Rosa.
Thank you, Sanusi.
Thank you very much. Thank you, Dr. Yonas.
Thank you, Rosa. Thank you, colleagues.
Thank you, everyone.
Thank you, colleagues. I miss you all. See you soon.
See you soon, Sanusi. Safe travels.
Thank you. Bye.
Oh my God. Who told you?